Hello, everybody. Hello, everybody. Please come on in. A very good afternoon. Welcome to the GE Healthcare Oncology Lunch Symposium entitled The Increasing Importance of Imaging in the Era of Advanced Cancer Therapies. My name is Mathias Goyen. I'm a radiologist and GE Healthcare's Chief Medical Officer for Europe, the Middle East, and Africa. During this symposium, you will learn about imaging's pivotal role in advanced cancer therapies. Specifically, we will explore innovations in early lung cancer detection and imaging in prostate cancer management that will help guide your personalized theranostics for optimal treatment. And I couldn't be prouder regarding our speakers today that I will quickly introduce to you. We welcome Professor Annemiek Snoeckx. Professor Snoeckx is the chair of the Department of Radiology at Antwerp University in Antwerp, Belgium, where she also coordinates the residency program. Her clinical expertise is thoracic imaging, with a specific interest and passion for thoracic oncology imaging. She's the founder of the multidisciplinary Flemish Lung Cancer Screening Task Force. She's a member of a number of lung cancer screening-related task forces, and she is principal investigator of the Flemish implementation pilot study. Annemiek, thank you very much for joining us today. The second speaker we are having is Professor Evis Sala. Professor Sala is professor of radiology and chair of the Department of Radiology, Nuclear Medicine, Radiotherapy, and Hematology at Gemelli Hospital in Rome. Previously, she was professor of oncological imaging at the University of Cambridge in the UK and co-led the Cancer Research UK Cambridge Centre Advanced Cancer Imaging and the Integrated Cancer Medicine programs. From 2012 to 2018, she served as the Professor of Radiology and Chief of Body Imaging Service at Memorial Sloan Kettering Cancer Hospital in New York. Professor Sala is leading multiple research projects focusing on the development and implementation of artificial intelligence methods for image reconstruction, segmentation, and data integration. Professor Sala was elected Fellow of the International Society for Magnetic Resonance in Medicine in 2015 and awarded an honorary membership of RSNA in 2022. Evis, we are delighted you join us today. And last but really not least, we have Dr. Ben Newton, our GM, Global GM for Oncology at GE Healthcare. Ben holds a PhD in immunology from Imperial College and did a postdoc at Berkeley in the US, and together with his team, he is focused on enabling an earlier diagnosis of cancer, leading to better care and better outcomes. And as he will explain later, GE Healthcare's technology is used all along the patient's journey from screening, diagnosis, and staging of the cancer through treatment planning, monitoring, and follow-up. Professor Snoeckx and Professor Sala will give a 20-minute presentation each. We'll then have time for a panel discussion where Ben Newton is joining. And now it's a great pleasure for me to ask Professor Annemiek Snoeckx to give her presentation. Annemiek, the floor is yours.
Thank you, Matthias, for the introduction, and thank you for inviting me here today to talk about my passion. 375,784. This is exactly the number of lung cancer deaths in Europe in 2022. But we as a radiological community, we have the power of saving lives through lung cancer screening. These are my disclosures, and I think the personal one is I'm biased because evidently I'm pro-screening. So what is the size of the health problem we're talking about? Well, lung cancer is the third most common cancer in Europe, with also a high mortality. It has the highest cancer mortality of all. And also important, if you look at the numbers, lung cancer from all the cancers has the highest economic burden. So the problem is huge, and it is expected that the problem will stay huge. There is an increase in lung cancer in women, there's a decline in men, but overall there is still an increase worldwide. And yes, we have these great new therapies. We have targeted therapy, we have immunotherapy, but it is still for a limited part of the lung cancer patients. And yes, we need to work really hard on a smoke-free generation, but I think we all agree that that is very difficult and that we'll need more for the years to come. So what is screening exactly? And when you talk about screening, you need to mention the first paper on screening. It's from 1968, but even now, it is really applicable on screening. It's the paper of Wilson and Jungner, published by the WHO. So the condition should be an important health problem. I think we all agree. There should be an accepted treatment and facilities for diagnosis. A recognizable latent or early symptomatic stage. We all know now how these early lung cancers look like. A test acceptable to the population, I think CT is evident that is acceptable. The natural history of the condition, we know how early lung cancer develops, a policy on whom to treat. It should be economically balanced, and I will talk about that later. And also important, case finding should be a continuing process and not just once and for all projects. When you talk about screening, it's important to realize that screening is different from early diagnosis. When you talk about screening, you talk about a population that does not yet have symptoms. We don't call them patients. Your screening populations, they're people, they're participants. So you don't screen patients, you screen participants. When you talk about early diagnosis, you will talk about people who have symptoms, are patients at that time, or the early diagnosis you find in patients that come into the hospital and incidentally you find a lung cancer. It's also important to differentiate early a population-based screening from opportunistic or wild screening. If you do opportunistic screening, you don't target the whole population. Your willingness to participate to screening is often higher, but it also comes at a lot of consequences in a negative way. Also, if you integrate smoking cessation, if you have a population-based program that is always part of it, in a wild screening, it's more random. And last but not least, quality assurance, which is extremely important for population-based screening, whether is it lung or other screening programs, but quality assurance is completely different when you do opportunistic screening. An important question, does lung cancer screening save lives? Yes, it absolutely does. We have the scientific evidence from a number of randomized trials, of which the NLST and the Nelson are the biggest one. In the NLST, there was a lung cancer mortality reduction of at least 20%, and in the Nelson, there was a lung cancer mortality reduction of 20% in men, and in women a bit higher. So yes, we have the scientific evidence. Also in this Cochrane analysis from 2022, which took into account also some smaller randomized controlled trials, there was scientific evidence that lung cancer screening with low-dose CT saved lives. The number needed to screen is also important when you talk about screening, and the data out there is somewhat variable. But if you look at lung cancer, the number needed to screen to save one life is between 130 and 320. In the Cochrane analysis, it was 226 to 296, depending on which information they used. But if you compare to colorectal cancer and breast cancer, the number needed to screen for lung cancer is even much favorable. So when you talk about screening, what are the essential key elements? Well, first of all, your target population, and that's a huge difference with the existing cancer screening programs, because all the other cancer screening programs, it's just age and gender. And for lung cancer screening, it's different, because we're only targeting a high-risk population, a population with a higher risk than normal to develop lung cancer, those who have smoked before at a certain amount of pack years, or those who are still current smokers. Extremely important for the future, and maybe not in the past, but for the future, not only for lung cancer, but all cancer screening programs, it is shared decision-making. Your participant to a screening program needs to be really good informed and needs to make a decision by him or herself based on the information that the person gets. And after having the information, he or she can still decide to not take part of the screening. But shared decision making is extremely important. The technical tools we use, and that's what we as a radiologist are interested in, low-dose CT, because if you always need to balance between benefits and harms, and you're using radiation is one of the harms for a population-based screening. But we have the low-dose CT, so we have the tools to do screening. And in the future, we will even have the possibility to reduce the dose to ultra-low dose. There's research going on to look into that. There's a new generation technology, not only based on hardware. We will have new scanners, new types of scanners. We have different imaging reconstruction techniques. So the technological tools to do low-dose and ultra-low dose CT, that is not the challenge for lung cancer screening. We need to look at the images and we need to know what early lung cancer looks like. But those in the room are probably interested in chest, and we all know now the evolution of hyperplasia to invasive cancers. So here you see a millimetrical ground glass nodule being an invasive cancer. We know what early lung cancer looks like. We need to find them, but we also have there the tools to detect these lesions and to assess growth. Assessing growth will be the only way for the future is by measuring volume. There's no way back, we will not measure diameters in population-based screening. We now have all the technological tools to measure the volume in a very accurate way. Once we've measured the volume, important to decide what to do with this nodule and to decide on which nodule management system. And there's a lot of nodule management systems out there. We will also be publishing one with European Society of Thoracic Imaging. I think when you use a guideline or a management system, you really need to realize for what it is developed. Is it developed for screen-detected nodules or for incidental nodules, or can you use it for both? So you need to make sure that you use the right guideline for the nodule that you see in daily practice. Communication is extremely important. How we will communicate? Well, this is a screening program. You will need a structured reporting in a very clear way that everybody can understand what you mean. We've already mentioned the smoke-free generation. It's not because we're doing secondary prevention that we can forget about primary prevention. Lung cancer screening should always be combined with smoking cessation programs, a very structured program that is clear for your population-based screening. The literature there is confusing in a way that the impact on the smoking cessation and how the benefits and how it would negatively impact, it's relatively inconclusive. So smoking cessation being integrated in your screening program is still an important research topic for the future. And last but not least, and that makes the difference with wild or opportunistic screening, when you're talking about implementing something on a bigger population, you need to have a quality assurance framework. You need to have quality assurance for every step in your screening process. And it's a vicious cycle. You need to collect data, register data, evaluate them, adapt your programs. So quality assurance is something that will never end and will never stop. And then last but not least, when you talk about quality and we're a radiological community, screening should be in the hands of people who know what they're talking about. And with European Society of Thoracic Imaging, we have the lung cancer certification project. There's e-learnings and webinars, and there's also an examination to get the paperwork that you need to be reassured that you have the qualities to do screening. So we already talked about the economical part, euros. Is lung cancer screening cost effective? There has been a lot of research out there and looking at the trials that have been performed, and yes, lung cancer screening is cost-effective in most settings. The research that has been done and the data out there is not always on a population-based level, but on a trial level. So most countries will need their country-specific evaluation. Like, what is our role? Because we're radiologists, what is our role in the screening process? Well, if you look at all the steps of the screening process, going from acquiring a low-dose CT, reading, reporting, and even after that, because it doesn't end at your screening process, a number of the participants that are there to get screened, they will have a diagnosis or they will have follow-up. And also there's an important role for us as radiologists. But the role I want to mention is the fourth that I call coming out of the dark. It's evident our roles in the reading and reporting, but we also have a role in all the other steps of the program. We have a role in monitoring. We need to be part of the quality assurance. We need to take a lead role in education. We need to step out of the dark and have a role in the public awareness, collaborating with others, setting up research studies, and be a part of the innovation. Radiologists should have the leading role in lung cancer screening. We're talking about next generation radiology, so evident that we talk about artificial intelligence. And where does artificial intelligence come in? I think it will come in many places. At the acquirement of your low-dose CT with deep learning image reconstruction algorithms, the software there for detecting, defining the volume, what your lesion is. When we have a lot of data from all these programs that will be implemented, we will be more able than before to have risk prediction models, even based on our own populations. And there's also screening for the big three, also incorporating quantification data on emphysema on your CT and coronary artery calcification. It seems all evident, all these 7 steps, but there are some challenges. We already said we will be screening a high-risk population, so a population with a high pretest probability. We see in the world that there is a shift from a categorical, like selecting participants on age and smoking history, moving to risk prediction models where we incorporate more the history, family history, BMI, COPD, asbestos exposure. We see more a movement to use of these risk prediction models. For now, it's only, especially in Europe at least, in Asia it's different, but it's only screening participants with a high risk. Europe, we will not yet screen non-smokers. Where will we find this population? And the population that we're looking for is a hard-to-read population. Smokers often have different beliefs about healthcare. There's a problem of inequality. There's also a population with a lower socioeconomic status. And also smoking history in many countries, registration in GPs records or in other records is really, really poor, and it's still on self-reported. There's also the false positive rate. There's nodules that we will find that will not turn out to be lung cancer. There's the data out there from the NLST with very high false positive rates, but we're moving along with our software, with our nodule guiding management systems, so the false positive rate is better than it was during these trials. Then a difficult topic is bias. It's not because you have a lung cancer that you would have died of this lung cancer. There's a number of lung cancers that we find early. People are living with a disease, will become a patient for a longer time than they would have if we have not done the screening. The number of overdiagnoses and the estimation what the impact is very difficult, but it is something that we cannot deny. A very difficult question, and I don't yet have all the answers for that, is what to do with the incidental findings. For the first time in radiology screening, we have an examination where we see more than just the organ where the tumor is. Even if it is low dose, we see the soft tissues, we see part of the upper abdomen, And we will see findings there that we, as a radiologist, will have difficulties not to mention, but we cannot send everything that we see on a low-dose CT for another examination, because it will impact your cost effectiveness, it will impact your healthcare system. So what to do with these incidental findings? It's a difficult one. The European Respiratory Society has made a guideline on that and has looked into the scientific evidence of mentioning these incidental findings. Also screening for the big three. There's more information out there than we're now maybe using. There's information on emphysema, there's information on coronary artery calcification, which also might have an impact for the future of this participant. Workforce capacity, we already have a lot of work. What are we going to do with all these extra CT examinations? Can we handle it? And it's not only for our profession, but it's also for the other professions. The expectations are that depending on the number of participants, you will see more cancer cases at the start of your programs, but then going down. So how to move from trial to practice? We have the scientific evidence. We know what the key elements are. We know what the challenges are. So why aren't we yet screening on a population-based level? Well, we're not, because what we need is implementation research. We need, on a level of your country, research to do to see on how to implement it for your situation. You need to have cost-effectiveness information, you need to design the infrastructure, integrate it with healthcare, have public awareness, address disparities, but last and the most important one, have policy makers on board. Europe is already on board in a way that they published Europe's Beating Cancer Plan, and that for the 4 key actions, early detection, cancer screening is one of them. And they included in the recommendation of December 2022 that countries should explore the feasibility for lung cancer, explore feasibility and effectiveness of screening for lung cancer with use of low-dose CT. And the European Commission is also funding and you might have heard the name already, Sala's implementation studies throughout Europe. For those interested to see what is going on in Europe, there's this interactive map from the Lung Cancer Policy Network, where you can see on a world level and define countries in Europe and all parts of the world to see what is going on. We have the tools. Let's work together to bridge the gap, to implement screening and reduce this ridiculously high number. Thank you for attention.
Thank you very much, Annemiek, for this great overview of the value of low-dose lung cancer CT screening. We'll have time to discuss the presentation later. I would now like to ask Professor Evis Sala on stage to talk about the impact of imaging in prostate cancer management, from tumor detection to theranostics. Evis,
thank you.
We're looking forward to your presentation.
Thanks very much, Mathias. Thank you, everyone, for being here. These are my disclosures. So what I want to do in the next 20 minutes is to actually highlight the role of imaging in prostate cancer management, because I think we're in a journey of linking the diagnosis to the management, as beautifully also explained by the previous speaker. This only comes through advancement technology, and not just on hardware, which is obviously important, but also on the software, on the AI support, and on a lot of other things that go along, like patient wearables and so on and so forth, but also improvement of the workflow. And then, of course, we're here to also talk about theranostics, integrating the diagnosis with therapy. And I know the theranostic is a term of nuclear medicine, so, you know, diagnose and then treat. But I just want to provocatively put out there that I think in the future the term will be even wider, because, you know, you will diagnose, but you'll treat with other means as well. So maybe in the future we'll see this a really organic, comfortable kind of merge and collaboration between the diagnostics and therapy, being that radiotherapy obviously one of the logical partners we have. So just 1 second showing you the module. I'm a very big believer that unless you build value with what you're doing, we're not actually doing much, okay? So it's not about a pretty picture. It's not about, something that I can spot the extra metastasis, but it's about, what I'm doing now is actually building any value to the patient. And this is really important. Imaging for a while was on that level 1 and 2. The pharma was much ahead of us, with clinical trials and the drug development. But now finally, we've really go to the stage 5, really providing therapeutic value, but also societal value, which is really, very important. So, just starting with the diagnosis of prostate cancer, and I think imaging has really a key role in the whole patient journey. And I think we have to start seeing the big picture, the whole patient journey and the whole pathways that a patient can take in prostate cancer, being a great disease in a way, because it allows you to explore all possible pathways, with being from indolent to actually aggressive. And I'm just going to advocate how some of it actually can be managed within the imaging department. Just highlighting a few really great studies, the PROMISE study being one of the key ones, but also a few other studies for active surveillance, especially the PRECISE, simple study, and then other important studies. But I'm just going to really spend 1 second on the PROMISE study, a really elegant work done by Ahmed Hamid, one of my surgical colleagues from England. And for the first time, actually, it shows that you can detect, just the last line there is very important, if you actually use multiparametric MRI to guide your biopsy and not go blindly, because we have these fabulous imaging tools, MRI with diffusion, you can detect up to almost 20% more cases of clinically significant prostate cancer. And look at what happened on the years. We almost don't do blind biopsies. The biopsies are actually guided by imaging. So absolutely caused a complete revolution in the way we practice. There are several screening studies. I wanted to highlight a couple. One of them published a couple of years ago at the New England Journal of Medicine, the Stockholm trial. And again, the most important results on this trial, you can see the trial design here, is that the MRI strategy, so when you actually guide your biopsies by MRI, you do first less biopsies, which is very important. So your biopsy rate will be reduced by almost 40%. Great, because the biopsies are not pleasant, I'm told. What is also important, there is no difference in the detection of significant cancers. That's perfect, so it's safe. But the detection of indolent cancers that probably we don't want to know, it's actually reduced. So this is building value to what we do. Highlighting another study, which is very important, it's not a clinical trial, but nevertheless, I think opened our eyes to how bad the PSA is as a screening tool, okay? So we have to think about it. Most of the men over 50 do a PSA test. If they have a normal PSA, less than 3, they go home, they're happy. Well, guess what? A fair amount of them have actually high-risk prostate cancer. So that PSA of 3, under 3, is not actually, any more acceptable in terms of what can do for the screening. So in that cohort of patients, 2 in 3 men with a positive screen MRI had a PSA of less than 3. They would have been reassured to go home with no prostate cancer. So this is actually one of the first studies who opened that big sort of, thinking that prostate MRI may have a value in screening independently of PSA. I'm saying may because, as beautifully the previous speaker said, you really need to do work to set up a screening program. And it's not as easy because MRI is expensive, but we can actually make it cheaper, more accessible and all that. One word about the PRO-based trial. This is screening men which are younger, so we're pushing to 45. And this is the preliminary results, but in essence, what this trial shows that is feasible, screening patients, younger men, But the PSA might be a little bit more specific. So again, another group of patients that we have to consider for screening. Now, this is actually one of my favorite slides because it's a bit of work to do here. So if one would say that, well, it's great to screen with MRI, but it's also equally important to report those MRIs well. So it's time for us radiologists to get off the fence and not put too many pirates free. Because depending how you want to play with the biopsy rate compared to detection rate, you really need to really up your game, or we do rather. So, you know, if you actually have, and where is the best place? Oops, I think it's not working. So where is the best place you want to be? Obviously, you can screen everybody with a PSA over 1, but then you'll be here, and you can biopsy them. You can be here to a high detection rate, but you have to biopsy 1 in 4 men, which is actually not feasible and not right. So where you really want to be is you have to be a PSA above 1, but then you only biopsy those with pirates 4 or 5. So it's work to be done. And how the technology helps? Well, obviously better MRI scanners, but also AI-enabled detection of tumors with the decision support embedded, not just I can segment a tumor, but how likely is this tumor to be high grade? So, and triage that this patient automatically to biopsy. Why not book the next biopsy? So the patient goes home with a plan. So this is how I see the MR. It's a lot of spin-offs out there, or the other vendors as well. Just listed a few here, which also can prioritize your workflow. And here, it's one of them, for examples. And as a radiologist, I sit on my console and I go, okay, it's a lot of orange in there. So let's just, I want to read those cases first because there is something there that might actually trigger a biopsy, and that needs to be arranged and worked out. Just talking a little bit about active surveillance, because this is another big group of people. And even in my 10 years of practice in different countries, I've actually seen a shift, even in the US, towards more active surveillance, okay? And less sort of aggressive treatment if you don't need it. Why? Because we now, as human beings, want also better quality of life. So active surveillance can give you that. This is a very simple score. Francesco Giganti, one of my collaborators, designed this score, and we use it automatically. We have it in our automated reports for prostate. And to the radiologists out there, just a very simple case here. A gentleman of 74-year-old, PSA is 5. You know, in 2020, you can see this small tumor, beautiful on diffusion ADC map here. Sorry, here at diagnose the T to the ADC. That's what diffusion changed, revolutionized prostate basically care. And then the patient comes back with a PSA that jumps at 7.2. You know, it's a little bit bigger, the tumor, the ADC has gone down, automatically the system will say this is a precise 4, and the patient at this point will need a biopsy, will need another treatment, being more active, i.e. surgery, focal radiotherapy, or they might be comfortable remaining on active surveillance for 1 more year. You don't know what the comorbidities are. So this is where I see AI starting triaging those patients very nicely, improving our workflow and improving our efficiency. This is our current reports, a part of the rotating prostate that which we produce at Gemelli. And of course, it's templated, so it's got all the information you need for data mining and data integration, but it's got a patient-facing and a surgeon or a biopsier-facing part as well, with annotating where the lesion is and also significant images. That has changed the way I speak to patients. Rather than showing them a bunch of text and they don't actually understand very much, I go and I say, look, this is where your tumor is. This is the map of the biopsy. I think this needs to be biopsy because the pirate's 4 or 5. It's going to be safe. It's going to be guided. And you're going to see the surgeon that day and that day. And they go out happy. The patients go out happy if they have a plan. And this is really important. And of course, there is, you know, if the patient goes to surgery, we can do very nice 3D mapping to actually help the surgeon on probability they would have to do a nerve sparing on one side, both sides, or not at all, as a matter of fact, or even not operate. because to add to this, now there is some beautiful work. This is recently an updated algorithm providing that probability of actually being able to do nerve sparing. Think about integrating this into your workflow. Not only you've done the diagnosis, you've said what the biopsy is, but you've also given the medical team, the tumor board, the probability of having a nerve sparing, and this is really important. There are other treatments. This is another case. AI is actually doing the job, detecting that the tumor here is gone out of the capsule, anterior extracapsular extension. We all know in the anterior part of the capsule, it's very, very difficult to have a negative margin. So this patient would have to go for radiotherapy. Well, of course, PSMA PET is negative, so fine, no metastatic disease. But what we can do, we can actually dose pain. We're going to be precise on the radiotherapy. So what we call the interventional radiotherapy. Pity this movie wasn't working. It will have shown you the 3D of the prostate with the radiotherapy rods being more intensified within the center of the tumor and less at the normal gland. So really delivering high precision radiotherapy, but also sparing and having less toxicity on surrounding tissue, so lowering the rate of impotence and incontinence. We know now biomarker goes also up to treatment selection, as I told you already, but also very simple work here out of Memorial Sloan Kettering Cancer Center, showing that MRI leads to almost half, so a reduction of men undergoing radiotherapy and those undergoing radical prostatectomy. And of course, the beauty is the simplicity of the thing. We designed this 5-point scale, and you can see here in this large cohort of patients with 15 years of follow-up coming out of Sloan Kettering again, that it's beautiful, the categories beautifully correlate with disease-free survival and the overall survival. No focus suspicious prostate lesion, you live forever. If you've got advanced disease, your likelihood of survival is lower. Now, moving to the theranostics part, of course, this audience knows very well, is the combination of the diagnostic and therapeutic tool, which is related to the same molecular target. Of course, you need your surface receptor has to be overexpressed. If you don't have overexpression, you can't actually use it. Different radionuclide with a various half-life, and just a few of them, at least on those slides. And we now have evidence from multiple trials that actually it does work. We know that in the setting of metastatic castrate-resistant prostate cancer, up to 30% of patients will develop such a situation. And we also know there is a need for a durable clinical benefit on those patients, especially when other options, such as some of the chemotherapy options, are actually limited. So luckily, in prostate cancer, PSMA is overexpressed, more than 90%, and those who is not, then you have the mismatch between FDG PET and PSMA. So then you're in that situation, you've got to use the FDG PET. The most common radiopharmaceutical, it's listed there. And it's a few papers now. There is a consensus that EU, EM, ESTRO, ESUR, Snoeckx, the whole societies together. I think this is the beauty of it. All the societies working together to actually provide precise indications. So I just want to highlight one important fact. The value of novel imaging comes and only comes when it shows that next generation imaging help maximize treatment benefit, not because it's beautiful, not because it's new, but because it builds value. It minimizes under-treatment, important, and also reduces over-treatment, of course, while tampering with the toxicity and the costs. So now we know that PSMA PET is actually the fulfills all of the criteria. We really now based our decisions based on the molecular imaging. One word of caution, okay? it's highly because the PSMA PET has a high specificity more than high sensitivity, it should be trusted, and it is trusted, to intensify the treatment and to suggest treatment escalation, but not de-escalation. We don't have evidence enough that you can de-escalate on treatment, which I think is fair enough. Just listing here the various tracers, and you would see there is advantage and disadvantage to all of them, but again, really very useful in our everyday clinical practice. Actually, now it's a routine in our institution to have a PSMA PET for all the indications that I presented. Just highlighted here the case in about 20% of the patients, you don't have the expression of the PSMA, and this is a discordant PSMA PET CT with obvious FDG PET CT in this case. You know, we have to be aware, you know, that like the other tumors, like ovarian cancer, it will be 10%, will be marker negative, so expression negative. So I don't want to, I mean, this is a simple score design how to report it. It's important, like we did with PIRADS and the template reports for the MRI. We've got to do the same for the PSMA, for all the other agents, because consistency is also very, very important. So we know it's safe, we know it works, we know it from the Vision trial, so that's great. So we've got excellent evidence. You know, other indications? So there are a couple of papers which are really, really nice. One, the therapy trial, again, excellent, advanced disease. Can we actually use it as a second-line treatment instead of chemo? Or even postpone chemo. So now it's all about postponing. So the patient has got so many treatment options. So you turn a cancer into chronic disease because you've given this opportunity to actually have new weapon in our armoire to actually prolong the life of the patient, keeping a good quality of life, which is really important. And then, of course, the lutectomy, you know, highly aggressive local disease, prior to surgery or not, maybe just take out the, maybe do a lutectomy of the lesion. Maybe in an elderly population with a lot of side effects, maybe this could be an option because it has less toxicity. So a lot there going on. Again, this is just a recap of the THERA trial, and just you can see on yellow there the benefits actually of theranostics compared to the standard chemotherapy. So we are there, it's there to stay. Our role is to optimize it, how to orchestrate it from the diagnosis, from the MRI to the PET, to the treatment, and to the many treatment, and not just the theranostic for the sake of narrow meaning of theranostic. Think about how can you diagnose, you can then apply the theranostic, but actually maybe also on the base of of the PSMA PET, make a more intelligent focal radiotherapy. Dose paint, not just on the diffusion, but dose paint on the PSMA uptake. So all there, food for thought. Again, just another trial, the Vision trial, and you can see here the benefit in terms of both the metastasis-free survival, but also overall survival, which is also key. These are all the ongoing trials right now on that domain, which I think is very interesting. This comes to my penultimate slide, because I know I'm at 0. Other ligands as well, beyond lutetium, and I'll leave this with you because, you know, there is, I think it's wonderful to have that plethora of the possible tracers. Where are we in the prostate? MR is there, and it's going to be there for the screening to come, for guiding the biopsy, for planning the treatment. PSMA will fill the other gaps. Of course, there is no role for bone scan. There's no role for CT either, as a matter of fact. But as we did with the PIRADS, with the reporting system, we've got to do some effort also on the reporting of the PSMA PET CTs. And of course, you know, the therapy should be based on dosimetry. Some more work to do, but that's what we're here for. And I think what is great is that the whole field is coming together with a very good collaboration between the radiology, nuclear medicine, and therapy. And I think in the future, it's beyond the theranostics. The theranostics beyond the theranostics. And I'll leave you with that. Thank you.
Thank you very much, Evis, for this great presentation. Please stay on stage, take a seat, and I would like to ask Annemiek and Ben to join us here on stage. Evis, maybe the first question goes to you. You talked about the enormous possibilities that theranostics brings, no matter how we define it. This is the theranostics 2.0 that you envisioned. So talk a little bit about the role of the radiologist and of the nuclear medicine physician. And please tell the truth. Is this a turf battle? How does it work? How have you implemented it at Gemelli? I think you cannot say from next Monday on we do it. It's a process, it's a learning curve.
Yes, no, of course it's a learning process. I think I've been very lucky because wherever I've worked in institutions, the nuclear medicine and radiology has been always part of the same department. So it's been a constant dialogue with everybody respecting the knowledge, but also learning from each other. So that is one. Second is that with the new tracers, I mean, the radiologist is not just an anatomist, okay? So you go beyond with, and the era or the importance of diffusion, at least in prostate imaging, has made us go beyond the anatomy of the uninant CT for PET, So what we do actually in our PET session, we report together. So there is a very good collaboration between the radiologist and the nuclear medicine physician. We also have a research facility, a tracer facility, which is actually in a very good collaboration with the rest of our facilities, with the radiomics, with the computational pathology. So what we've tried to create is an ecosystem which works together, one each other, and it's not a turf war.
Just a quick follow-up question on that. Do you even have an exchange program with regard to the respective residency programs? So between radiology and nuclear medicine, like 6 months, I go there and come back?
We don't, but we have, it's interesting, I think you probably read my mind. We are actually thinking, because I don't know what it is in the rest of Europe, but we're seeing, at least in Italy, we're seeing a decline in the number of applications, especially for radiotherapy and to a certain extent also for nuclear medicine.
Right.
So I think what is telling us that we knew, but we weren't going to accept it easily, is that the disciplines would start to converge a little bit.
Right.
Because the future is the integrated care.
Yeah.
So I think we are planning at least to do it first. We actually thought radiotherapy and radiology. But yes, so let me go back and work on the other one, nuclear medicine.
Thank you. Annemiek, I guess everyone in this room, after an excellent presentation, now sees the value of low-dose lung cancer CT screening in a risk population. Just think of, biomarkers now coming into the game. Would this be even a game changer? Would there be even better results? It would be great if you could just share your ideas. There are so many biomarkers, it can be confusing. Are there trials where you add the biomarker and then you're even better?
I think regarding the biomarkers, there's still a lot of work to be done. There's research on different type of biomarkers, but there's not a magical biomarker yet. I think also the way we look at biomarkers, we might need to change that in the future, because we're now looking for biomarkers to search for the early lung cancer and to have a high positive predictive value when your biomarker is positive, that the chances there is a lung cancer are high. But I think we need to shift to look at the biomarker maybe from another perspective, because we talked about screening participants with a high risk of lung cancer, because we're now defining the population that has been smoking, but we know that with the current criteria, 50% of the lung cancers that are there would not apply to the lung cancer screening criteria. So finding a biomarker that not maybe find all the lung and not like also would have participants that would not have lung cancer, but at least would have some small risk. Then if you think further, now we're looking at smokers, but there's also the environment, pollution, there's also other things going on. And that if you would have a biomarker as a first tool rather than your criteria, it could also help to recruit participants, because you would take away some of the stigma. If you would have a biomarker to select them, they would be selected because of the biomarker,